Hitting the record button. All right, I would like to welcome everybody to our March Public Health Preparedness webinar. We are very excited to have one of our program graduates back tonight to speak with us. But before I turn it over to him, I just want to make a couple quick announcements. I apologize for not having a slide like I did last month, but I will have one next month. First announcement is that we are going to be having a meeting of our Emergency Management Club later this month. We're working on a speaker right now, and we'll be sending out some more information about that shortly. If you are not on our mailing list and would like to be, please get in touch with me, and I will make sure that you are added. Second announcement is that we will be having our April PHP webinar on April 3rd. Again, it's the first Wednesday of the month, again at 8 o'clock. So a flyer will be coming out about that as well. So we hope to see you there. Last announcement is that we are planning a great elective for this summer. It's going to be a look back on COVID and some lessons learned and some evaluations of things that were done. So we're really excited about that and are going to be sending out a flyer. So that way, if you are looking for a class this summer, we would highly encourage you to look at it. It's going to be really great. So we also look forward to seeing you. So now I am going to introduce Dr. Mike Mitchell, who is, as I mentioned, he is a graduate of our program, graduated back in 2021. And prior to that, he received his Ph.D. in cell and microbial bio from the Catholic University of America. And he has an MS in biosecurity and biodefense from the University of Maryland. For 15 years, he was a research microbiologist in academic, government, and industry labs. And then in 2013, he left the bench to become a government contractor and biology SME. His first contract supported the Marine Corps Combat Developers Writing Capabilities requirements for biological detectors and MCMs. Then he joined LMI in 2015 and has since served on contracts that are supporting CBRN MCM development for the DoD at DTRA and JPEO CBRND, and a biological aerosol detector technology demonstration project for DHS. During COVID, just like our summer elective, he returned to JPEO to support COVID MCM development efforts, and then he moved to the HHS Coordination Operations and Response Elements, which he's going to talk about tonight, at HHS ASPR, where he provided front office support and later served as a vaccine field coordinator for HCOR's Supply and Procurement Division. Since March of 2023, he's been supporting projects in the Innovation Capability and Modernization Office to strengthen the defense industrial base. So, Mike, thank you so much for talking with us tonight, and we look forward to hearing about your work.
All right, thank you. So first of all, I wanted to start off by thanking you all for the invitation to be on the speaker side of the webinar this evening. And as proof, I decided it would be appropriate to wear, my Penn State PHP swag here to prove that I am indeed a graduate. I also was going to say that with the emergency management meeting, I shall be in good old sunny Cleveland, Ohio for the Nacho Biopreparedness Summit. So hopefully I'll be able to join that from my hotel room there. To tell you all about the exciting things going on. It's been a long time since I've actually done any sort of public speaking, so I'm definitely pretty rusty, and I'm not sure exactly how this will go, but I hope you don't suffer too much, or those at home don't suffer too much on this. Second, I think I should start off with sort of the usual disclaimer that what I'm sharing tonight just kind of represents my own views and opinions and observations from my time at HCOR, and doesn't necessarily reflect the views or opinions of either any of our government clients or of my employers. So tonight, what I wanted to do was just talk about a few of the non-medical obstacles that I observed while I was there for 15 months at HCOR, and hopefully, I'll be able to get through it in enough time that we'll have time for discussion and questions at the end. Since there's just a few of us here, it's easy enough to just kind of have this as a nice little fireside chat discussion and so forth. But just feel free to interrupt me along the way. If you got any questions, I'll try to answer them the best I can. Usually I'm one of those types where it's like, I don't do so great with the questions, at the moment, and then like an hour after the talk, I'll be like, oh gosh, that's what I should have said. So we'll see how I do there. Um, so you went over my background, and I think from there, I wanted to point out that while I was yeah, after graduating from Catholic University and after my postdoc at National Cancer Institute in Frederick, where I was in the HIV drug resistance program, I went out to Salt Lake City for a year. I got a job as a research microbiologist for a small biotech company out there, and was only there for about a year before I got they had massive layoffs, and I ended up returning back to the Northern Virginia area, where I struggled to get another job in a biotech company. So I ended up settling for a second postdoc at the University of Maryland. And it was there where I took advantage of their tuition benefits program and ended up enrolling in a master's in biotechnology studies that specialized in biodefense and biosecurity. And, I was still kind of I still had shell shock from my layoff, and thought that that would be a profession that wasn't likely to go away anytime soon after that. So when that grant ended, I did finally break into the contracting world, and my first job, as you mentioned, was with the combat developers with the Marine Corps. I was their biological SME doing capabilities requirements writing for their medical countermeasures, as well as for, as you mentioned, the JBTDS, which is the Joint Biological Tactical Detection System, as well as for some of their modeling software, biosurveillance portal, GEM, JWARN, etc. But I really wanted to be in medical countermeasure development. And so I managed to, after a year and a half with them, I switched to another contractor, the Tory Group, and with them, my first contract was up there at JPEO, supporting the chief technical officer. He had me doing, I was helping him out with management and oversight of all these medical countermeasure projects that they had, and in vitro diagnostics and so forth, because, there was all these integrated product teams, et cetera. And, he couldn't be everywhere at once. So he just needed somebody present to kind of keep track of risks and any decisions that need to be made, and back brief them on those kinds of things. And this was during the West Africa Ebola outbreak. So it was kind of an exciting time there, because the DoD definitely had some Ebola vaccines in development that they were trying to leverage and get into clinical trials and so forth, and provide data for that response. I was only there for a year when I had the opportunity to do a lateral change and went over to a contract at the Defense Threat Reduction Agency, still doing vaccines now, but at a more lower level, at an early developmental level, when things were transitioning from concept to early development, animal models, preclinical work, etc. I was there for 3 years. While I was there, I also Tory Group and a lot of these government contracts were big on having people that had their project management certification. So while I was there, I studied for and passed my exam for my PMP certification, and got that in October 2016. I was there for the tail end of the Ebola outbreak, and in 2019 is when Tory got acquired by LMI, my current employer. And as a result of that acquisition, they ended up booting us off the contract. And so they didn't want the competition around, was basically what what the problem was. And so with that, I had to find another position within the company, and that's how I got in on that BD21 Biodefense 21 project, which was where I was a technologist that was kind of evaluating the current state of the art of biological aerosol detectors to see whether or not they could replace the aging BioWatch system out there. When I joined Tory, when I joined LMI, I noticed that they had a very generous employee benefits tuition program. They actually offered $15,000 a year for us in exchange for indentured servitude for 2 years afterwards. And it was there that I sat down with my supervisor and was asking him like, okay, I'm interested now in public health. I really wanted to get away from the DoD what if scenarios of there being, you know, warfighters being slimed on the battlefield, and was more interested in the actual um, real life possibility events like, you know, Ebola, with the possibility of people, you know, bringing it over here to, you know, domestically, or pandemic influenza and things like that. And so that was the direction I was starting to shift. And I was starting to look at master's programs and was trying to decide whether or not I should be in a master's of public health program that had a track in homeland security or biodefense, or if I should be in a homeland security program that had specialization in public health preparedness. And because of the sort of contracts that LMI had, where we were more with DHS or you know, DoD, HHS, wanting to be in that arena, we decided that it would be better for me to do something of the latter rather than the former. And so that's how I came to join, enroll at Penn State. So I was on that BD21 program when COVID started, and it was in June of that year that I then got rolled off that contract and needed to find another position, and had the opportunity to go back to JPEO, this time to headquarters, where I was supporting the assistant JPEO for medical. And my my job title was actually DoD liaison to FEMC, and FEMC is the Public Health Emergency Medical Countermeasures Enterprise. It's a mouthful, but basically they were trying to ensure that the Strategic National Stockpile had the capabilities it needed to respond to either CBRN events or to emerging infectious diseases and so forth. And it's definitely at the time HHS was leveraging projects that the DoD had, and I thought that I was going to be the representative on these interagency meetings for the DoD. But in fact, they actually used me to kind of do more of what I had been doing back in 2015, which was that management and oversight of the ongoing CBRN medical countermeasure projects, while they all dealt with, you know, there were a lot of people at that program that were doing double duty and were project managers for COVID countermeasures and so forth. But they needed somebody to kind of monitor the risks and the decisions that needed to be made with the ongoing projects for when the emergency was over and they went back to their day jobs. My boss was set to retire in February of 2022. So I decided that I would try to find another position within the company. And as luck would have it, LMI had just won the contract for providing contract support to H-Corps. And so in November of 2021, I switched from JPEO headquarters over to HHS ASPR H-Corps. So with that recap of my background, so tonight I wanted to talk about, well, I should say with my time at Penn State, I really was inspired by the non-medical obstacle course that you offered. I think I was in the inaugural course for that one, and I don't know what the syllabus is like now, but I know that the modules that you had in that course I thought were very, you know, thought-provoking and really struck a chord with me, because by that time I had already experienced, you know, several non-medical obstacles that seemed to pose a, you know, like a challenge or a roadblock to you know, getting shots in arms or getting, you know, medicine in hand and so forth. Because you know, it's one of those things where you have a medical solution, but something else was interfering with it being successfully deployed. So my intention for this evening is to talk about 3 cases at H-Corps that I thought represented non-medical obstacles to H-Corps' COVID response. So the first thing I want to talk about is personnel resources and the idea of having the right person at the right time at the right place. And the second thing I then want to talk about is the issue of like public communication, public policy, and politics that polarization and how that can have an impact on H-Corps, how that had an impact on H-Corps' mission, and indirectly, but it definitely had an effect, or influenced the decisions that had to be made. And I want to talk about that with respect to the fall vaccine campaign of 2022. And then the last thing I wanted to talk about really kind of goes back to my first contract position and the idea of end user requirements and how sometimes that can impact the effectiveness of your response. And the two instances I wanted to bring up in that regard are the test to treat program that they had, and our efforts to try to expand access to a monoclonal antibody called Evusheld. So maybe I can pause there and see if any questions, or should I keep on going?
I'm just going to take advantage of your pause and make a shameless plug for the non-medical obstacles course, which we do offer every spring. It's PHP 810, taught by yours truly. So shameless plug over. So keep
And I
going.
remember both you and Jean, you also kind of co-taught the one. There was like a COVID response course that we had, like there in that first summer of COVID as well, and that I also found that very that really was interesting as well. But at that time, I would have been still with that BD21 program, so I brought some of that experience or some of those thoughts to my jobs at the JPEO headquarters and at H-Corps. So well done. Okay, so so as I mentioned, I started at H-Corps in mid-November of 2021. And H-Corps stands for, and I always have to look this up, but H-Corps stands for the HHS Coordination Operations Response Element. I don't think there's any ands or commas in there, but H-Corps was being stood up as a permanent office in January of 2022. They were the successor to the Countermeasures Acceleration Group, which itself was the successor to Operation Warp Speed. But as I mentioned, H-Corps was being stood up in January of 2022, but we arrived in mid-November of 2021. If you look at any references, if you can find any references to CAG on ASPR's website, you'll see that they were involved with advanced development and procurement of COVID medical countermeasures. H-Corps, I think there was the name change also, I think, reflected a mission change, because H-Corps was their mission was procurement and distribution of medical countermeasures. So when we arrived, they were in the midst of this transition. You had CAG was still a temporary office, and you had a lot of people. It was being staffed by military and civilians that were on temporary detail, and they were coming to the end of that assignment, that temporary assignment, and they were preparing to go back to their day jobs, or some of them were making the decision to actually transition and become permanent, a permanent part of H-Corps. In addition, they were also starting to do a bunch of new hires to grow the organization. But I'm not certain about this, but the one thing is that when we arrived, it was still one of those things where we were 100% on site, very empty building, and they parked us up on the 7th floor of the Hubert Humphrey building, in the central conference room that had been actually used as the EOC, the Emergency Operations Center for Operation Warp Speed, and we were parked in there, and we would go for days at a time sometimes without seeing a government government sponsor or whatnot. I'd get there, I'd say, tell our program manager or our contracting officer representative that, hey, I'm gonna go down the hall, see if they need any help with anything, what I could be working on, etc. And I'd poke my head out, look down the hall, and I'd see that the doors were closed, the lights were off, and etc. And I'd call them up and ask them, like, what am I supposed to do? And they said, well, you're not supposed to be there without a sponsor, so really you need to pack up your stuff and go home and telework from there. So it was kind of like, thank goodness, I think they were at a position now where they could kind of go through this transition, because because the government had their medicine cabinet in place. They had placed their orders. We were starting to get to a point where there was actually a higher supply than a demand for the vaccines and so forth. And I think they were able to. The fact that they had this little situation was thank goodness it didn't happen during the time of Operation Warp Speed or CAG, because that would have been quite the disaster. But I actually had at one point, I don't know if it was somebody from the front office or if it was somebody or if it was our core who ended up saying that that we had actually arrived sooner than they had expected, that they were busy with actually trying to get all these people onboarded and doing that whole transition, that they weren't expecting us so soon, at least the first batch of us anyway. So you actually had a situation where there were, like, on our team, there were chemists that people were being put in positions and were doing tasks that were definitely outside their area of expertise. You had chemists that were doing supply chain management and logistics. You had there's a toxicologist and a pharmacist on our team that were doing data analysis related to the ordering portal. I was supposed to be, my job title was vaccines and therapeutic subject matter expert, and I was finding myself just doing a lot of, like, glorified secretarial work and administrative duties and everything, and helping to cut and paste charts from the CDC into the PowerPoint presentations that the director was giving to the White House COVID task force or something. Or because they were doing this transition from CAG to HCOR, the outgoing director was also trying to prepare documents that were kind of formalizing or documenting the standard operating protocols that they had used in making their allocation decisions, et cetera. So it just struck me as one of those things where I remember from the course, if when we were reading Dr. Henderson's account of the smallpox eradication effort, it was one of those things where he talked about just the importance of just having these fantastic people on the team that really made things happen. And it just kind of felt like this was just the exact opposite. It was one of those things where like they had a bunch of people that they had purchased us, and they didn't have anything good to do for us. And that kind of came into play later on. If you might remember that in 2022 there was the monkeypox outbreak, as well as there was the issue with the baby formula supply shortage. And that was something that they had wanted to leverage HCOR to help out with the response. And the contract for us actually was specific to COVID response. So it was one of those things where our program manager actually told us that we couldn't work on anything monkeypox or anything baby formula. Like, if it came up in meetings, if we could excuse ourselves from the room, we should leave. If we were on a call, we should drop if we could. But definitely, you're supposed to be seen and not heard on those issues. And so, as a result of that, of kind of finding out that you had these contractors that couldn't help you on, couldn't support you on those issues, I think they ended up, as a result, they needed to rewrite the contract. They ended up competing it again. So initially it was a 5-year contract with 1 year base, 4 option years, and in the middle of that base year, they ended up putting out a request for proposals, and it was in September or so of that year that we found out that we had lost we didn't get awarded the contract, and so we were going to be dropped, and they were going to be bringing on a whole new crop of contractors. Because those contractors weren't successful at poaching us, they ended up extending, doing a bridge contract, etc. And that's why I was there for 15 months until the end of February in 2023. And the other, what was the other area that lost my train of thought on that one. It'll probably here's a prime example of something that'll probably strike me later on, oh, go back to that and think about this one again. But the other thing that gosh, oh well, it'll come to me. But it was one of those things where with the the other thing that I noticed was that when it came to the domains, and like they had a little bit of, I don't know if you'd say like buyer's remorse, but it was like one of those things where they certainly kind of realized that they didn't need some of the labor categories that they had initially got. And I don't know if that was because they kind of got the contractors at the same time as they stood up this H4 office, and only realized later that, oh, we really should have had really needed this more than we needed that or whatever. But anyhow, that was certainly the first sort of non-medical obstacle that I had witnessed. The the second one, though, that I wanted to bring up, which I thought was interesting, was just sort of the impact that public communications and public policy and even like the political environment ended up having on H4 operations. So it was around this time in 2022 that and as I was saying, I was providing front office support, that they were having discussions about the fall vaccine campaign for that year. So they had noticed from the data from CDC with the COVID trackers and whatnot that it would be around September or so. Well, you would start to have an uptick in cases and hospitalizations and everything, either when you had extreme heat and people were going indoors, or you had the weather start to turn kind of a little chilly and people started to go inside and started to have their holiday gatherings and whatnot. And so they were anticipating that uh, COVID would have another surge in the fall of 2022 that would probably correspond or correlate with the influenza season. And so they were starting to make these decisions that, okay, if we're going to have this fall vaccine campaign, we actually need to start doing production now. We need to start getting these companies on contract. We need to start working on what the formulation is going to be. That was at the time when there was, Delta was still circulating, but there were hints of Omicron starting to become more prevalent and so forth. And there was a bivalent, updated bivalent vaccine that was in the works that they expected. But again, it was one of those things where if we're going to go with that, we need to start making it now. And the question was, how much do we need to make? And Biden at the time had said that everybody who wants the shot will be able to get the shot, and hopefully even those people who didn't want the shot would agree to get the shot and everything. And so if you look at the numbers for how many people had gotten at least one dose or had completed their primary series, it was something like 94 95% of the population had gotten at least one dose. And I think something around 70 or 71% had managed to complete their primary series. So that became the basis for they had three courses of action that were based off of projections of demand. Like high demand would be that everybody who had gotten, the range for high demand was pretty much corresponding to those people who had gotten their either one dose or were fully vaccinated with two doses. So that was the high demand range. The low demand range, I think, was based off of just historical seasonal influenza vaccine data. And that, if you look at the CDC website, was somewhere around like 50%. And I think the medium demand was based off of how many people had come back and gotten their first booster. I think there was something like around like a 30% drop off between fully vaccinated and that first booster. So I think the range for the medium demand was assuming that either everybody who had gotten a booster would come back and get their second booster, or maybe there would be a similar drop off of 30%-ish or so, and that would be kind of like the low end of the medium demand. But but the issue certainly was that you had to start making those plans so far ahead of time, and they didn't know how many they needed to order. And I think because of that promise, I think they decided that they really needed to go for ordering enough doses to really vaccinate everybody. I think internally they were thinking it would be somewhere more around the 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 medium demand. But they didn't quite know what that was and didn't really want to take the risk of not having enough then. But I think certainly the fact that there was, just out there in the public, the sort of the fact that there really wasn't any discussion going on about issues in terms of, like whether or not, I think data started to come out where it was like one of those things where you started to hear those rumblings of like, well, like, the vaccine is definitely offering protection and preventing hospitalizations and deaths, but is it really preventing transmission? Is it one of those things where gosh, it's just one of those things where the over 65 are the ones that are really at risk, and they're the ones that we should be focusing on, or is it really one of those things where everybody should be getting it still? I think it was becoming a little bit more obvious that like the vaccine wasn't providing sterilizing immunity. So, but there was kind of a lack of that scientific discussion actually filtering in and influencing the decisions. H-Core, I think, felt bound or ended up deciding that they needed to go for that high demand as opposed to like discussing like, well, maybe we just need to have enough vaccines to cover that medium level or even the low demand, so forth. But those decisions had to be made before the fall vaccine actually came around. And so by that time, I had moved on to supporting somebody else at H-Core. But when the data actually started coming in, I think they were really shocked and surprised because it came in at far below expectations. If you look, I thought I knew the number, and actually when I did some digging around, I found and kind of confirmed, but it was actually 17% of the general population ended up going back and getting the updated bivalent vaccine booster. And so, I mean, that's like a third to a third to a half of what normally got the seasonal influenza vaccine. And I think that really took them by surprise. It really shocked them that the response was so low. And I don't know, I just couldn't help but feel that it certainly was one of those things where, like with all the, and they discussed whether or not was it a case of vaccine fatigue? Already that number, that low estimate took into account the expectation that, either the anti-vax people or the vaccine hesitant people might not come back and get it. But I think it really took them by surprise that everybody else wasn't, even the ones that did support it, were not coming back in numbers to get boosted. Um, and so it certainly was one of those things where H-Core was definitely just executing the administration's policy. They weren't involved in those discussions or so forth. But I just think that it was just I don't know. It was one of those things where H-Core, I think, learned their lessons from that. I mean, I think that was definitely a big disappointment, but I can't imagine that for 2023 or for now, if they're making the decisions now for 2024. I think they definitely learned their lessons and aren't going to make a similar mistake. But I think it was just one of those things where I'm glad that it's a good thing that it was for COVID and it wasn't like a more dire pandemic than it was. But it certainly was one of those things where for the future, I think they won't make a similar mistake. But the non-medical obstacle that I kind of observed here was just that, I don't know, you just always have to imagine that politics and such was going to muff things up in one way or another. There was a lot of, I guess, just that issue where there was that spillover effect from other areas that H-Core and HHS didn't really have any control over, whether public trust in the government over things like the economy or immigration or J6 or anything like that was kind of having the spillover effect where their lack of trust or their resistance to anything the government said because of that spilled over then to their kind of attitudes as to towards the virus here. So I just feel like that's one of those things where in the future, you're just going to have to imagine at least some sort of risks that politics and communication is gonna play. Um, I can go down other rabbit holes when it comes to like some of the DEI efforts or whatnot that were being discussed there, but uh, if you're interested, but otherwise I'll just come back to that if we have time at the end. But the last area that I wanted to talk about,
Mike?
yeah,
Yeah, I'm going to take you up on your offer to interrupt you. Very interesting, and I'm also concerned I'm going to have to jump off before I get to ask my question or to
okay,
have a conversation. So, in first year, um, in a significant part of what you're relaying, these I don't know whether you call them failures or at least obstacles. Um, Did you participate, or actually, this is a pretty naive question, but I'm just thinking about after action reviews. And so did you as a contractor, did the contracting agency participate in that? Have you seen those things? And I'm sure it's, it's massive if there is a single one or there's many, many of them. So my question is it's not a easy one, but I guess I'm just always kind of intrigued by after action reviews and
right,
have the sense that they typically get done and then filed away, and the people who
memory
participate
will,
in them, well, the people who participated in the event and writing the report benefit, but not too many people, other people do. So
right.
did you guys participate in that kind of review generation? How did you yeah, I guess I'm just wondering, how do we learn from this? How does the institution learn?
Right. Yeah, I think I agree with you that some of it is where it's like that tacit knowledge or whatever um that so long as somebody from that time still exists, that like maybe it will still come up. Certainly by the time um we had already left that contract, by the time I think some of those things were being considered or written down, I know that they did. They did focus on lessons learned. I did have the pleasure of listening to a webinar from one of the people who was involved with actually the next area I was going to talk about with the test to treat program and the Evusheld access. And I asked her at the end, because I was saying with the test to treat program, did they with the things that ended up that they had to go through, did they learn the lesson? And were you confident that in the future that they would um, do better on that? And she thought that she believed that they had, and I just feel like I have to take her word for it. She she had left the organization, so she didn't really have um,
Hmm.
anything that she was trying to protect or anything like that. I think she was giving honest reflection on her time there. Um, so I have confidence that in all these areas that they've learned their lessons and will be able to apply them for the next time, or that they won't, especially with the first thing with the personnel and everything. I think those were just some of the like the growing pains. All these things I felt like were kind of growing pains for the organization since it had just been stood up. And I think for the next time, I think they won't necessarily have those issues.
Hmm. Hmm. Yeah, I guess I'm just dreaming of this big, massive library with all the after action reviews that one could go through and, in the heat of battle and learn directly from them without having been in that battle before.
Right.
Uh, yeah, yeah.
Yeah, I remember with one of the other contracts, I think with the Marines, it was one of those things where I found a way to access some lessons learned archive or report, and it was very
Hmm.
sparse in terms of actually having lessons learned in there.
Hmm. 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 Yeah, that's, just getting back to our program 594, for example. So for most of our students, we really push on them doing some recommendations as well at the end of after their review. So, yeah, I'm going to have to start thinking about those after action reviews pointing that out to our students as they're writing their recommendations.
One of the
Interest.
one of the books that I had started reading after my time there was that came out recently was lessons from the COVID war that
Right.
that a group had done that Andy Kiliansky. For some reason I feel like we had him as a speaker at some point or whatever, but he contributed to that stuff, and it was just interesting to see them talk about like lessons that weren't learned from things like the avian influenza scare back in 2008, or like they talked about the fact that everybody mentioned how the Obama administration had done this pandemic influenza plan or whatever, and this criticism of that was like, well, really, if you kind of read it, it wasn't much of a plan at all. There was no action plan in there. It was just kind of a lot of talk and everything. So, but he still kind of concluded that the Biden administration had learned a lot of lessons, that he felt kind of confident that they wouldn't make the same mistakes in a future response. So I think there's hope.
Yeah, that scene, you hold up that book. There's a book that I was going to get it, but I haven't. I think it was a series of essays from the dean of the medical school at Yale, maybe, who wrote them, as COVID was going along, and for, I think, a magazine or something like that. And then they compiled them into a book. But it was, similarly about sort of what he was observing and learning as we went through COVID. And it was a series of essays. That was, yeah, interesting. I'm glad you brought up that book.
Yeah, I'm starting to try to accumulate all these books from both sides, but I don't have the patience to go through them and deal with all their finger pointing and projections and covering their butts or whatnot. But at some point I'll sit down there and try to do that. There was another one that I pulled out from my bookshelf to have on hand, like this one, the first, it's all backwards of course on the screen, but the first shots by Brendan Borrell was something that had come out just as we got that contract at H-Corps, and our program manager was like, you gotta read through this and get up to speed on that. And by the time I got there, there was only 2 people in the book that were still on staff. Gary Disbrow is director of BARDA, and he was still present, and had a lot of conversations with. I didn't have conversations with them, but I mean, I was on a lot of staff calls that he was present on. And then, what was her name? Anita Patel was sort of the second in command there at in CAG, and she was rolling off and was there overlap with my time just for a couple of weeks. But I always felt bad that I didn't bring that book in and have her at least sign the the inside front cover of it for me. But
okay, very good.
Yeah.
Thank you.
Yep. So the last issue that I wanted to talk about was end user requirements and how that kind of came back as a non-medical obstacle. And the 2 cases that I wanted to talk about were the test to treat program, which I wasn't on that team, but I was adjacent to it. The same person was heading up the test to treat and the Evusheld program. And then the other one I want to talk about was what I just mentioned, that Evusheld access. So with test to treat, the test to treat program was this therapeutic point of dispensing model for the oral antivirals. And I guess the idea of this had been conceived about a year before it went into effect. But and I guess the ideas for it were quite different than what actually ended up coming out. But it got kicked into overdrive when Biden mentioned the test to treat program in his 2022 State of the Union address. And so they now, as a result, they had to quick get this thing up and running. And what was different about this certainly was that if you think about it, like the normal progression for the influenza-like illnesses is that, of course, you feel crummy for a day or 2 or whatever, and you decide that, maybe I really ought to go see someone about this, and you go to your primary care physician or to your clinic and so forth, and they diagnose you, they write out a prescription for you, you take that to your pharmacy, and you get your treatment regimen to take home and start taking. But test to treat was different in that now in this model, you actually, you're going to your drive-through clinic, you're getting your brain poked with a nasal swab, you're sitting there waiting for the results that come back 15 to 20 minutes, 15 to 30 minutes later, the pharmacist writes out a prescription for you, fills that prescription, and then you go home with your medicine. Well, so the issue here was that the pharmacists, they don't write prescriptions, they don't do the diagnosis, they just fill prescriptions. So it was really, it was an interesting problem or dilemma in the sense that these pharmacists aren't your healthcare professionals that are supposed to be making this diagnosis. Actually, when Googling around and trying to jog my memory on this, I actually came across a flow chart that was put out by a pharmacist organization that really was, almost like a triage, like how to triage patients to see whether or not they are qualified for the oral antiviral Paxlovid. But it was one of these things where, as a result of this this treatment model, they ended up having to, and the fact that pharmacists weren't supposed to be doing this kind of diagnosis and prescription writing, they had to go about getting waivers in effect to do this outside the normal flow of events. And I don't know whether or not they, now as a result, I don't think they have implemented this for seasonal influenza or for RSV or anything else that might have a therapeutic available or whatnot. But it'll be interesting to see, kind of like you mentioned, that whether there was a lesson learned for this and whether there is a future pandemic influenza or there is some other outbreak, whether or not they'll kind of remember this and realize that they need to go about kind of getting this waiver process going so that you can again have this sort of test to treat issue. Another thing also with that was that when it came to the dispensing of these oral antivirals, they certainly didn't want those people who were symptomatic with COVID actually going to a clinic and potentially infecting other sick people or other people that were there in the office. So it was just it was an interesting thing where they had to kind of really think it through of how are we going to get this into their hands rapidly, because the effectiveness of these oral antivirals was definitely that they were most effective within 5 days of the onset of symptoms. So you couldn't really have, time was of the essence, and you couldn't have it that normal flow where, you're waiting for the person to actually decide that they feel crummy enough to actually go to the doctor, to get the diagnosis and get the prescription to go fill it and everything. So that was just interesting where they had to kind of conceive of this new model in order to rapidly dispense the oral antivirals. The other area, though, that I was working on was Evusheld access. And Evusheld, if you're not familiar with it, Evusheld was a cocktail of two monoclonal long circulating antibodies that were an alternative to getting the vaccine. The label, the indication for these was for people that were either had a weakened immune system or were otherwise contraindicated for receiving the vaccine, that it wouldn't be effective. And usually, the people that this applied to were either ones who were, had a chronic condition where they were either had a weakened immune system or were immunosuppressed. So a lot of times it was like organ transplant patients or people that were undergoing chemotherapy, for example. The problem with this was that with this drug, it was administered intragluteally. So you had two vials, two syringes that I can't remember if the volume of each syringe was 1.5 mils or 3 mils, but you got a jab in each butt cheek. with this monoclonal antibody, and it was supposed to be good for protection for up to 6 months. And the issue was that we were trying to, number one, educate the public on its availability. And HHS had established both a vaccine locator for the public to use, as well as they also had a therapeutics locator that primary care physicians could use. But Evusheld didn't really fit neatly into either one of those categories. It was a vaccine, but it wasn't administered the same way, and it wasn't a therapeutic, and it wasn't like the other monoclonal antibodies where you went to an infusion clinic and got infused with that antibody. In addition to the fact that you got the jab in each butt cheek, there also was a 1 hour observation period that was supposed to follow the administration. And so it was really a challenge because I was on the team that ended up doing a lot of phone calls to pharmacies. Actually, we started to look and realize that these patients, this patient group was served by specialty pharmacies. And a lot of sometimes you'll find that places like CVS or Walmart, thanks, Gene, you would see that these specialty pharmacies were the ones that treated these patient groups, and we would call them up and we'd ask them, like, we would tell them about Evusheld and say, you know, are you interested in this product? Are you willing to receive it and administer it to patients? And a lot of them said that, well, we think that it's a good product. We'd like to be able to offer it to our patients, but we're actually not set up to do that kind of thing. If you think about it, like when I get my shots at my local CVS, it's one of those things where, you check in at the counter, you go sit in a little chair, the person comes out from behind the counter, and maybe behind a screen they ask you to roll up your sleeve and they give you your jab. It's not like where they're set up for you to go and drop trow and have a shot in both butt cheeks and then sit there for an hour. They would say that they also didn't have the personnel to sit there and watch you and observe you and make sure that no adverse events occurred and so forth. So there was the fact that they might not have a little room for you to go in there to have the privacy while you sat there and got your shot in the butt and whatnot. But so that was one problem, that they just weren't set up to handle it. And then the other issue, we also tried to work with some of these specialty pharmacies that offered home care. And that was an issue where the problem was that the government was offering their reimbursement rates for Evusheld was not enough to cover the costs that were incurred by the specialty pharmacy. Some of them, like, they offered this home care, but they had like a 2 hour minimum for the home care provider. And so it would be one of those things where if the government was only reimbursing an amount that covered 1 hour, it was one of those things where it wasn't covering the costs. We also found out that they were some of these specialty pharmacies, they would dispense the therapeutic to the specialist office, the primary care provider. But there were dispensing fees and white bag fees or whatever for doing that. And again, the dispensing reimbursement rate, or the reimbursement rate for that stuff was pathetic. It was something like, it was definitely less than $10. I want to say it was even like $1 or $2. It was awful. It was something that definitely didn't cover the cost. And so it was one of those things where they just said that we'd like to be able to provide the service, but it just isn't in our financial interest. We're going to go broke distributing this stuff out there. So I felt that it was just one of those cases where the government could have benefited from having people that spoke to the end user and kind of tried to understand what their capability requirements were, and be able to bring that back to actually work on the development of, the product profile of these things that the government had in their medicine cabinet. I think that was what I was trying to remember, back with the first obstacle, where it came to, I felt like H-Corps didn't need technical specialists that were subject matter experts in the development of these products, because BARDA had their scientists and consultants that provided that ability. They really could have benefited from having technical experts that could, go to the end user, understand what their capabilities were, and make sure that the product that we were offering was able to, meet that capability, and was going to be able to satisfy like the concepts of use or concept of deployment that the pharmacies and the health departments were going to end up using. So gosh, it's already 9 o'clock. All right, so yeah, so just in conclusion, going back to Gene's comment, though, I think with all these non-medical obstacles, the personnel resources, the public communications, and the reality of polarization and politics and everything, as well as sort of these end user considerations, I think that these were all things that H-Corps did actually learn lessons from, and obviously I don't know where H-Corps is now in terms of their operations and so forth, but I'm confident that they took these lessons to heart and will be able to apply them for whatever the next public health emergency actually is that requires these sorts of models and considerations. And so, all right, so with that, I'll stop there and see if either of you two have any lingering questions that I can try to answer.
That was great. Thank you so much for giving us that behind the scenes, and I'll give you a chance to take a breath. I know that you gave us a lot in that hour. One question that I have, kind of tangential to everything that you've said, and I'm a contractor as well. So we have a lot of students who come in thinking about, CDC, USA Jobs, DHS, and I've often encouraged people to kind of open up that aperture and look at contracting jobs, things like that. So would you have, I mean, obviously you've done a ton from that contractor perspective. So would you have either advice about how to go about looking for contracting jobs in this area, or just any good advice coming from the contractor side?
Yeah. So thinking about that, and some of the people I've worked with, it's interesting in the sense that I felt sometimes with the positions that I had, the government was interested in, with my scientific background, a lot of times it was one of those things where, especially with the product development stuff, like they really wanted to have people with scientific backgrounds that had done their little stints in industry or whatnot and had a familiarity with those areas. And I always felt kind of left out of that because I had done a lot of basic research stuff and hadn't done the advanced research stuff, the FDA regulated kind of work, et cetera, and lost out on those kind of opportunities. At the same time, though, there were people like when you made the announcement on LinkedIn and Dave Bailey commented on me, and knowing me from MCS up at Fort Detrick, there were people on that contract where their background wasn't actually in scientific, like in medical countermeasure product development or whatnot, but they had a background more in the project management side of things. And I was always a little bit envious or jealous of them because some of them got tapped to be the assistant program manager on some of these like vaccine and therapeutic projects. And they learned a lot about their particular product and were very well versed in that stuff. And they went on to become then, they ended up becoming like civilians or having these more prominent roles in the organization compared to me. So I think you can kind of approach these positions from each direction. You can either bring, like that project management experience, or, some other administrative role, supply chain management experience and whatnot to it. Or from the other direction, you can have your more of the knowledge-based stuff and learn the other stuff on top of that.
And you're also unique in the sense that you've got your PhD, you've got your PMP, and you also have your CEM.
Working
So
on it. Yep. Closing in on that, I hope.
close. So I mean, you've got the academic side, the professional certification side. So you're hitting it from both angles.
Yeah, and some of my other contracts are definitely were people that came in that to the organization that got their foot in the door in areas that maybe they didn't really want to do. They were capable of doing, but didn't necessarily want to do. And as a result of being in the organization, they kind of had that first dibs on that lateral transfer within there. I know that there were people that had done internships with the HR department, for example, or with business development or whatnot. That then when they won that contract, they kind of were able to get in on it. So that's another route sometimes that you can take. And yeah, and I also feel like, from my background, you saw that how I had bounced around from all these different labs. I bounced around from all these different types of contracts with DoD, DHS, HHS, and I feel like I'm starting to reach that point where I'm bringing all those experiences and being able to offer something that that's unique or so forth.
So I also think it's interesting. I often talk to people, again, coming from a contract side, taking a step back, and not that there's anything wrong with CDC or anything like that, but looking at some other places. And me, for example, I'm doing CBRN stuff with the Coast Guard. You did it with the Marine Corps. So neither one of those are going to be your first thought for, oh, I want to do biodefense, so I'm going to go call the Marines. But if you get into this field and start really researching it, you find these opportunities. And funny story, the guy that I work with, who runs the Coast Guard CBRN program, is a retired Marine. So you can find these opportunities in places that you would not think to look, but they're kind of all over, especially when you're talking biodefense and public health and emergency management. You can kind of find it wherever you look. So
Right.
that should be very encouraging to people that are looking. It is almost 9:10, so I really appreciate all the time you've given us, and I want to be respectful of your evening. So is there anything, either piece of advice or anything? I know students can always, if they come to our EM meetings, you're always there, and you come to these things all the time. So I know that we can definitely get a hold of you and we can pick your brain some more. But just as a closing for tonight, is there like one good piece of advice that you would leave students who are trying to do awesome stuff like you've done, kind of how to get there? And
You put me on the spot because yeah, off the top of my head, I can't think of that one piece of advice. There was the one when we were talking in that last EM meeting, and they were talking about just the importance of getting good writing skills going. And I thought that was just something that was I wholeheartedly agreed with that stuff. But I
actually,
don't know.
I'm going to answer my question to you for you with an answer that I know that you would pick. So one thing that you have been a big proponent of, even though you might not mention it, is you do things like IAEM, you're involved in our EM club, you go to the IAEM book clubs. So I know that you've mentioned like listening to webinars and doing this and doing that. So there is a ton out there. So you don't
Yeah.
have to fly cross country and go to some major conference. There are a ton of opportunities that you can do from home. Like Mike has mentioned a couple of them. And Also, we can't say enough about networking. Like Mike is
Yeah.
active with all of our LinkedIn stuff. He's active with the IAEM Region Book Club, which we did post a video about. Actually, I have to post a video about that, but Mike sent information out about. You don't have to be a member of IAEM. You don't have to actually even read the book. If you just want to listen to EM practitioners talk through emergency management books and like real world examples and things like that. So, my question for you, my answer to my question for you, you take advantage of all of these great opportunities, both in things that you get to learn and also networking with people who you can learn with. So,
Yeah.
I wholeheartedly agree with Mike doing that. I think that both of those have values that you definitely cannot put a price on. So,
The networking is big because I know it was one of those things where once becoming part of the Penn State program and becoming part of the LinkedIn groups, like both the PHP and the IAM club, I definitely went in there and looked at all the other members and sent out invitations to them to connect with them because it really is one of those things where you discover that it is a small world. Um,
mhm.
yeah, I don't know when Dave was part of the program. I mean, I assume that he was part of the program at one point, Dave Bailey. But yeah, I mean, the fact that I worked with him and I didn't know that or realize that until later on and looking through the list of LinkedIn people that I found out that, oh, hey, Dave, I didn't know that that we had this common connection.
So there we had a speaker about it maybe about 2 years ago now. We've been doing this religiously for about 6 years now. So the speakers of all or the timing all kinds of blends together. But a captain in a public health service captain who I work with at the Coast Guard, he started in the program after me as a student, but finished before I was TAing and teaching. So I had missed him completely. And we were talking, like we worked together and we were talking and like public health preparedness at Penn State. Wait, I was there. So, it's a very small world. And we definitely the LinkedIn groups that we're talking about, they're unofficial. They're not like they don't go through the Penn State alumni office or anything. So we don't ask for money or anything like that. I'm probably not supposed to say that. So but we really our LinkedIn groups, we really use those just to stay in touch and post things that might be interested. So we definitely encourage people to join those groups, stay in touch with us. We love having our graduates come and listen to our webinars if there's an interesting topic. Speaking, just because you graduate does not mean that you have to be done with our program if you don't want to. The fact that we have so many graduates attend our webinars and participating in our EM club is actually something that I'm really proud of because I love the fact that we can have current students and graduates and faculty all working together and just advancing in our field. So thank you for posting your LinkedIn link in the chat.
Yeah.
And oh, go ahead.
Oh no, I was just going to say, happy to do that. And for those who end up watching this later on, just feel free to contact me there and connect. And yeah, so that you can just be part of the network and discover how it really is just a small world. But
All right, so last thing before you go is it looks like you are making a pretty awesome reading list over there with your COVID books. I just got one about, I think it's called Tell Me When It's Really Over. It was a look back on COVID, and there's also a really good one about the rise of anti-science that I'm reading right now. So if you could send me, or maybe if you want, post on your LinkedIn page or post to our group with some of those awesome books that you're reading. Maybe we can start a little chat there so people who are interested can kind of peruse. Um, but thank you so much for tonight. That was a ton of amazing information, and it was really great to hear it from the perspective of somebody who is, boots on the ground dealing with this day in and day out. So thank you so much.
thank you very much. All right. Have a good
See you
night.
in a few weeks at our EM meeting.
Yes. All right.
Bye,
Good night.
everyone.